Hello friends, welcome back to NRS Samay. Wherever you are in the world, a very warm good morning, good afternoon, good evening. Healthcare industry has certainly evolved a lot over the years. Let's talk about India. Initially, it was all about government hospitals and a doctor-patient relationship for sure. Then came doctors having these private clinics. Later, we have seen huge hospitals having bunch of doctors. And now we are seeing hospitals which are going the IPO route with, again, a huge shareholder base. Now, even more, insurance companies are controlling the healthcare industry. Forget about the rural part. It's completely in an isolated state. Most of the places, though. Overall, this healthcare industry has got commodified, and patient is not a person in pain or in need of help, but a source of money, income, or a revenue stream for doctors, hospitals, and the entire industry in an overall picture, in a nutshell. But let's take this too. How can a healthcare industry survive without money or a revenue stream? How can a balance be struck? Joining me now is Dr. Daya Prasad Kulkarni, the founding member of Arogya Seva, an international humanitarian volunteer organization that is dedicated to providing quality healthcare services to affected communities worldwide. And Arogya Seva also strikes the places where disasters are seen, and they've been in the Nepal relief effort and also the recent Chennai floods. The goal is to completely provide and decommodify the healthcare industry and imbibe a spirit of Seva. Dr. Daya, thank you so much for your time, sir, and welcome to the program.
Thank you very much for having me on this show and giving me an opportunity to share my story. Thank you once again, everybody, to listening.
Yeah, deeply honored, sir, definitely. So first thing is, I've listened to your YouTube video, and you talked about decommodifying the healthcare industry. Is that really doable, sir? What's the practical phenomenon behind this?
I know it's not something which can happen overnight. I realize it's a lifetime's work for me, which I may not even see during this lifetime of mine. But the work has to start somewhere. Also, I understand that money is important in the system, but it does not mean that an individual is deprived of a primary healthcare service or access to it because he or she cannot pay for it. And that is what we are looking at as decommodification right now. We're not saying the entire system will become free. There are models, for example, in the UK, if you look at the NHS, it works very well, even though they're having some troubles right now. But there are models which can work, can be brought into place. The system has to take responsibility and ensure that the community, the beneficiaries, are not deprived of an essential service only because they cannot afford to pay for it.
Right. Sir, you yourselves have been reading that you have never charged or probably never taken any money for your patients, right, when you see your patients, right? How is it really possible, sir? It's been almost years or more than decades, and you're completely into Seva, right? You've never taken any money. How is it possible, sir, even?
Again, this is a very personal philosophy of mine that I strongly believe, and traditionally it has been in the Indian tradition, that healthcare is not a commodity to be sold. So I believe that the skills that I have of treating a human body, which is actually a divine thing in itself, is not something which I can sell. So it's a personal choice that I have come to, and I have made my peace with that. And it is possible, but I understand this is not something everybody can do, or I'm not saying everybody should quit what they're doing and start doing what I am doing.
Yeah.
And that's exactly why the organization Arogya Seva has evolved, where it gives everyone opportunities to do something like this, but on a smaller scale in their own way.
Right. So also I've gone through your LinkedIn profiles, I've scraped through the internet, understanding you, very interesting, and I got to tell you, phenomenal work on your thoughts and every detail that you went through. I also gone through your website. You also had been an NRI, and you also had your education and other things in Hawaii. I've seen that. So you've looked into multiple models around the world, went back to India, and basically from Bangalore, you've started multiple initiatives. So what were your experiences when you go around the world in terms of healthcare industry, and when you go back to India, what thoughts roll in your mind, sir?
I think that's a very valid, important question, because this is what has led to what I'm doing today. Because 10 years ago, when I decided this is what I would do, I did not have clarity on how I would do something like this. But then I had the good opportunity to actually travel to all of, several countries, work with so many different communities in different scenarios. But what I understood in any of these places, be it Hawaii, be it New York or Phoenix, or Africa, Central Africa, or Southeast Asia, in all of these places, there is a community which needs, which is deprived of healthcare access and which needs certain services, which a lot of us have taken for granted. The situation, the factors in all the different places may be different, but ultimately the situation is the same. In Africa, it may be, civil war, it may be conflict. In some remote part of Chhattisgarh, it may be a Naxal problem. In the Northeast, it may be because of poverty. In New York, again, it could be because of poverty or lack of insurance. Right. So the factors may be different in any of these places, but I realized that the need is everywhere. Even when I go back to a city like Bangalore, which is the hub of healthcare and education, there are over 1,000 slums in the city of Bangalore. And there are people living right next to a big apartment complex or a big hospital who don't have access to, basic amenities. So this is what I have learned, and as I have traveled, and that's also one of the. But what I've also seen is there is good work happening in a lot of these places. People everywhere want to do good, want to do seva, and that inherent quality is there within all of us, but it just needs a trigger and the right kind of platform to engage with.
Wonderful. Sir, arogyaseva.org, ARGYASEVA.org is the website. I would request all the listeners to go see that website. Phenomenal information there and a lot of details. How does it work, sir? What sort of network have you built in, and how does this whole philosophy work?
Right. So the idea is to get every stakeholder in the healthcare service delivery space to volunteer, to commit to volunteer something. I have done work with larger organizations like Doctors Without Borders, MSF. They do amazing work. I have a lot of respect. I have learned a lot from them. They have very good standards. They have good protocols, and their volunteers are all very committed. But the limitation is that they have certain restrictions for volunteering. You have to commit 6 months to 9 months, if you want to go work with them. Also, you have to work only in the areas where they have operations, which are mostly conflict-ridden, war zones, or disaster areas. But I understand that not everybody is ready to do this. They all have their own commitments, they have their families, and majority of them, though, want to volunteer, cannot leave everything and go away to a war zone and risk their life. Not everyone is made for that.
Right.
So how do we tap into all of these individuals who want to volunteer but don't have the opportunity? So that is how the whole idea of micro-volunteering and flexibility has come in, evolved. So what we do in Arogya Seva is we have different levels of volunteering. You can choose what you want to commit. You could volunteer 1 day in a year, or 1 day in a month, or 1 day in a week. So you choose what you want to do depending on your commitment and depending on your availability. And then we will find the right opportunity to engage with you and make sure that that period is utilized. And it's also very flexible. You don't have to go all the way to maybe Central Africa to volunteer. Within your own neighborhood or even in your own clinic. So we have the concept of Seva hour, where a doctor says, I'm very comfortable sitting in my own clinic and volunteering.
Wonderful.
So he allocates an hour, of consultation time. Say Friday between 4 and 5 is my Seva hour. So people within that neighborhood who don't have, who need free medical care are either brought there through our non-medical volunteers or partner NGOs so that they can get their consultation. And then you have next level where you can step out and go into your neighborhood, maybe in a government school or in a slum. A little more is once a month you go into a rural village which is just outside your city. And then if you're a little more adventurous, then we have opportunities where you can go to the northeast or Chhattisgarh, or then there are situations like Nepal and Chennai which emerge where you can volunteer to go offer your services in these situations as well. So it is a very progressive, scalable kind of trigger, but it also helps because you start small and then you realize that this is something you want to do. You feel good by doing this, so you want to do more and more of it. So you naturally increase the frequency of volunteering as well.
Fantastic. Friends, I'm in conversation with Dr. Daya Prasad Kulkarni, founding member of Arogya Seva, AAROGYASEVA.org. It's an international humanitarian volunteer organization dedicated to providing quality healthcare services to affected communities worldwide. Dr. Daya, yesterday I was referring to a few people that potentially I would be talking to Dr. Daya, who started the ArogyaSeva.org. And he has mentioned to me that in the conversation, a friend mentioned to me that many a times the idea of patients is to just see a doctor. He's in pain. He wants to see a doctor who can give him some sort of a confidence, He cannot talk to his wife. He cannot talk to his family, or he or she. Let's take it that way, putting besides a gender bias in the conversation as well. Mm-hmm. So they want to see a doctor. They can't talk to their friends and family and then say that, I have this pain and somebody understands it. But potentially talking to a doctor itself gives them a sense of feel. Forget about the doctor giving some suggestions or giving a medicine, right? The biggest medicine is seeing the doctor. Did you, by any chance, think about offering services to someone on Skype or social forums? I know it is very complicated when you talk about a medical condition, but my friend referred saying that, hey, can you ask this particular thing to Dr. Daya? What are your thoughts on that?
I think that's a very important issue considering the situation. For example, more than 70% of the medical human resource, that is doctors, are concentrated in less than 30% of urban centers. That means majority of the Indian population have recently a friend of mine wrote an article and he shared it with me yesterday. There is a village in Chhattisgarh where he is right now, where villagers have to travel 76 kilometers to go to the nearest health center.
Wow.
And even then they're not assured that there will be a doctor there. Right, so this is a situation. But then, because of the advent of mobile phones, things are changing, and that is something we have actually started to offer. We did try this a little bit during the Nepal earthquake, and we had this during the Chennai earthquake, where we had a helpline where we were offering medical advice through our volunteers who are distributed across the world, who are ready to take calls and offer advice to medical, either paramedicals or nursing staff or junior doctors, or even non-medical volunteers who are actually assisting with pregnant women and senior citizens who are stranded during the Chennai floods. We also had a counseling line available in local language if somebody wanted to talk. So yes, there is definitely scope to do that. And because we have this network of volunteers who are spread out across and they're willing to take this, we are working on setting up a toll-free line actually right now, and offer maybe tele-consultations, tele-advice. And also for within the U.S., there are a lot of doctors, volunteers I know, who are who may be not able to physically travel to India, but who are always willing to offer specialist advice and second opinions and review cases over the telephone or the Skype or the internet as such.
Wonderful. Thank you, sir. And when we talk about Arogya Seva, when you started off, it starts off with a thought, and then you'll see a natural progression in terms of ideas, in terms of how to ramp it up, and you get a lot of ideas from the people whom you're interacting with. The scope widens up, right? So what was it when you started Arogya Seva, and how did it eventually evolve? How many volunteers got involved? Volunteer doctors got involved? What did you learn through this process, sir?
So when it started, it was just me going out and doing what I could as a doctor. This started after the tsunami in 2004 when I had just graduated and become a doctor. And I went there to Nagapatnam because I was a fresh doctor, and I thought, oh, now I'm a doctor, I can change lives, I can save lives and change the world. So I went off. And then I continued doing that as an individual. I traveled to several villages over years. I worked with MSF, with WHO, doing some consultation work with them. So I was doing all of this as an individual. But then slowly the idea was, if I continue doing this all my life, I will be able to reach, X number of people. But then the more I traveled, the more I realized that the need was huge. And then there is this whole set of resource which is there, which don't have the opportunity to volunteer. So how can I get more people to do what I am doing? Maybe not on a full-time basis, but on a small scale. So that is how the whole idea of micro volunteering evolved, because then I knew if this becomes a model, people can start volunteering. Everybody in the healthcare fraternity can start volunteering to some extent, and then that pulls up and becomes a significant contribution. So that is how it slowly evolved. And yes, there are a lot of ideas that are coming up. We have just started student chapters in medical colleges, because we know this has to start from early on in the medical education itself. We don't have so much of a stress on volunteering, on humanities in the Indian medical education system, whereas in the US there is some of it which is there. So we've just started Arogya Seva student chapters in medical colleges. So they start early on and then understand what the need is, and then maybe get attracted to volunteering as well when they become doctors. We also realized while we were doing all of this providing healthcare is that we don't have certain technology, for example. We don't have certain devices when we are in remote places. Either they are too expensive, or they may not be suitable to be used in those setups because there is no electricity or continuous electricity, or it cannot be carried there. So what we also kind of started last year was a open source innovation platform for affordable medical technology.
Wow.
So these are all new ideas that are evolving and that are of real importance and can actually help us serve better, improve the quality of care that we provide by doing all of these additional parts of the jigsaw puzzle, which I call, actually, which will then come together to form this big picture of holistic quality healthcare to the community.
Wonderful. So let's talk about the Chennai relief efforts. Fantastic efforts, have selfless souls, and you guys are just awesome. The whole thought itself is something beyond imagination. The entire medical industry itself, for a normal person, is intimidating, and it's also very tough to understand how to survive in this hostile environment where the drug companies, insurance companies, hospitals becoming heavily revenue-driven organizations under extreme pressure and all of this. Right now, looking into this Chennai Relief, I know that you've done phenomenal work on Nepal efforts. We'll definitely touch base on that if we have more time. But Chennai Relief and the kind of work that you already mentioned about, what are some of the challenges in offering treatment? And most importantly, what kind of medical attention do the people need? What did you learn, sir?
I think as it happens in every disaster year after year, and this year we've seen 2 back-to-back, a lot of times the situation is that the local groups are caught unaware and caught unprepared to face a situation of this scale. Mm-hmm. Even though they are ready, eager to offer whatever they can, there are no services, there are no resources that are immediately available to help. For example, we had a lot of senior citizens who were evacuated from their homes because the water level was rising, right? But when they left, they were shifted to maybe temporary shelters. But a lot of them were diabetic and hypertensive who were on regular medications. But then when they were evacuated, they just had to leave. They did not think about taking their medications with them, or the people who transported them did not know that, okay, they need to have medications on a regular basis to avoid complications. But because of the stress that was there in the situation, maybe not enough food and water, dehydration, and no medicines which they were supposed to take regularly, there were several, challenges that were there. So these are very simple solutions. If they had access to their regular diabetic medications, they would probably have been normal and been able to even help others. But these were some of the challenges which we saw in an urban kind of setup, where there were a lot of people who were on regular medications but had to be moved out and then did not have access to those for a while. And when the relief work was happening, people were focusing on more emergency care. Not many were thinking right away about medicines for diabetics. Who would think of that in a situation where people are trying to save lives from floods? So these were some of the challenges that we faced. There were a lot of, pregnant women who were stranded in different parts of the city and who needed help with delivery. So these were some of the challenges that we faced, that the city was caught unaware and unprepared in many ways.
Sir, and the services that you guys offered is pretty much on ground and off the ground, because you also mentioned that you have opened helpline, and so on ground you would have seen some of the devastating insights into what has happened, and how do your team offer help. Can you give us little of your details in terms of what happened on ground and off ground? What sort of calls you received off ground in that helpline?
Right. So I will give you one example. Mm-hmm. What happened in the third day, I think, in the middle of the night, around 1 o'clock, I received a message saying that there is this senior citizen who's 85 who is having difficulty to breathe and cannot be carried to a hospital, and there is no access. So we took that call and gave them advice on what medicines they had available, what the situation was, how serious was it, and tried to stabilize the patient for the night. and we were on call and available just in case it had to be escalated. So we were able to, have the situation under control for the night. And then early morning, we had a team of doctors and volunteers actually go to their place, visit them, and assess the situation and provide whatever treatment was required and stabilize them. So in the first few days, it was actually teams of doctors and volunteers and nurses who were going out to places and offering treatments. And then slowly, once the water receded and it started stabilizing, we started having more like camps in the relief centers and in the neighborhoods. And these were out of minivans, these were out of cars, where they were the doctors would sit in the van, and then the community, the neighborhood would gather around and then get treated. And then gradually it shifted because now things are coming back to normalcy. We are having camps over weekends. For example, today and tomorrow we have camps in some of the relief centers and a school and a institution for orphan children. So that is how it has moved from actually the doctors visiting homes to neighborhoods to now weekend camps and stabilizing the process. We also had initially teams of volunteers going on motorbikes, for example, vaccinating, giving TT vaccines to the volunteers and helpers who were actually on the ground doing all the work, and they didn't have the time or the resource to come to a center and get vaccinated. So these are the kind of work that we have been doing.
In terms of the helpline, you would have got these calls, right? Whatever you've mentioned, the old lady who's suffering.
Yes.
Phenomenal. Amazing. So you would have seen earthquakes, floods, and cyclones, right? And when you see these sort of disasters, right, what is something that the people should be aware of, and what is something that you guys take quick steps in common? Can you highlight such things, sir?
Yeah, definitely. I think the important thing is there are certain agencies which are ready to respond to any of these situations. For example, because we've been doing this on a regular basis, we were ready to respond like on day 2, even like late part of day 1 itself. Mm-hmm. So there are agencies like ours, and that is a great thing that there are several other groups who are ready and who are willing to come on board immediately, which is their specialty. So having access, these teams being available and talking to each other, coordinating with each other and working together is very, very important in this kind of situation, to exchange information, to share resources, to also get local contacts and local feedback as to what area is the worst hit, what area needs more support, and things like that. So exchange of information and talking to different agencies is very, very important. The government also plays a very key role, and having a good relationship with them and sharing information with them and giving them assistance rather than trying to do everything on our own is, I think, the best policy to follow to start with. And then slowly there are other agencies which will kind of come and take over, who specialize in long-term rehabilitation and long-term care.
So let me step back a little bit, and then I would request you, paint us a picture here. So let's imagine there is a Chennai flood disaster that happened, okay? And you get to know that there's a disaster. What happens in terms of, you get to know that something of this happened. How do you immediately energize your chain, which is like volunteers, local groups, self-help centers or medical facilities working with government agencies? Can you paint us a picture on how it all transpired in terms of the Chennai flood, sir?
Yeah. So I think, again, it's a learning process. After every response, we learn so much new, and we have from this as well. So what happens is, initially there is the news reports and there is tweets. Again, social media plays a very important role in this. There are Twitter, messages, and even local people talking about a situation. Say there is, unexpected, unprecedented rain. So for people who've responded before, there is a trigger. So, okay, this looks like if it goes bad, it might end up becoming a disaster situation.
Right.
So we are on, the prepared situation, waiting to see, okay, should we respond or should we just wait? And then there is a point where you know that if you don't respond right now, it might, be too late, and you have to start responding because the situation is getting worse. So we do a local trigger, basically. We try to mobilize our local volunteers who we have and build the connections also with local groups, so that we start getting some information to know if the real situation is actually bad, is it getting worse, and if they will need help. So once we start getting that information, we start having things in place. For example, once we started getting information from some of the volunteers in Chennai, the situation is getting bad, we started getting all our, say, doctor volunteers ready there to have them prepared. And then we also started setting up our volunteers who have helped us with previous disasters to be prepared just in case there is a need, to start collecting medicines, to have collection centers, to have contacts who can pick up these materials and who can be ready to go. And then we also will start putting together some of these kits which will be helpful for the teams that are going. Right. So once that is in place, and once we decide that we have to respond, we have local teams which will be mobilized first, and then they come together and start, because by then we would have started getting rescue calls or messages or tweets from different agencies that, I get a WhatsApp message saying, okay, 80 people are stuck in this IT company that with 3 pregnant women and they have not eaten, so we need some help there. And once we start getting these, we start mobilizing teams locally, and then by then there are groups which specialize. For example, there's a group called In Crisis Relief, whose expertise is to bring all these resources together. They create a local database. People start putting their contact information that they are available in this area to provide information, to provide support, and this is their contact number. And then we have a medical database which is also created for the particular disaster. And then we have a resource database. So we start putting up a needs list, for example, for people. And then by then we have all the other people in unaffected areas who are ready to contribute, who want to provide something. So they should also know what they need to provide, because not every disaster is the same and the needs are also not the same. So we start putting up a needs list. What are the most important medications that we need? What are the other supplies that they can buy and drop off at these collection centers? And then there are teams who are sorting and putting things together so it can be shipped. So we have transport being arranged. So it's a whole chain of things, and there are different events that happen simultaneously, and then there are different groups which are monitoring and engaging with all of these different pieces, which come together very, very well because of communication and because of sharing of resources. And that is very, very important. And we've seen a lot of that in this Chennai response. People have been very cooperative, very considerate, and also very proactive in engaging. There has been no ego clashes, or there has been no use of resources, or misuse of resources in that sense, I would say.
Wonderful. Yeah, I definitely see that Chennai's the way as volunteers have worked and people have come together, even when the mainstream has neglected it for quite a while. So, unbelievable set of people who jumped in and then did a phenomenal job. I know rehabilitation is real long term. We don't know how long people can sustain. That's where the bigger issue is, and there should be some organizations which can pick it up. But when I hear what you have said in terms of the way you have reacted to the Chennai relief and activity, pretty intense and pretty real time. You should keep changing your decisions on a fly, collecting kits and mobilizing resources with all that you've got. And hopefully, it gets streamlined as you evolve, probably using these Uber services. I've seen a lot of things come through over the past. And this whole idea of creating a helpline where people can call and creating that call centers is unbelievable. Phenomenal work on that front, Dr. Daya.
Thank you very much.
Sir, I understand from your website that doctors can be of some help here.
Yes.
Yes, it's completely flexible, not like the other Doctors Beyond Borders and other bigger initiatives.
Mm-hmm.
And also, people who are not doctors also can get involved, right? Can you give some insights on how people can get involved? And far beyond, if anybody cannot involve in any aspect of this, how can they basically help donate in terms of cash, kind, or whatever possible ways?
Sure. I think the idea is for everybody to be involved, to have a chance to volunteer in some way or the other. We specialize in not saying no to anyone. Anybody wants to volunteer, we will find something for them to do. So that's the best part. So for people who want to volunteer, medical, of course, there are definitely several volunteering opportunities. You can sign up on our Volunteer With Us page, give us your specialty, give us how you want to volunteer, how often you want to volunteer, and we have projects in different geographies. So if you're in India, you can volunteer there. When you're traveling to India, for example, a lot of our doctors, we have 4,000 plus volunteers in the US, who a lot of them travel to India for vacation every year. But in those vacations for 2 weeks or 3 weeks, they can take a few days to volunteer with us, and we find a suitable project which is close to where they are located, so they can share the skill sets they have, not just in terms of treating patients, but also with the local teams to build their capacity. So it's not so. Every time you're traveling to India, also you can let us know and we will find some opportunity. We have regular medical Seva Yatras which happen in different parts of India every year. So you could sign up to volunteer there. And it's not just doctors. We have nurses, we have paramedics, we have counselors, we have spouses who come and help us with the administration, with the logistics as well. But it's not just about doing a medical yatra once a year in India and finishing with that. And a lot of them cannot even travel to India. So we also have now projects within the US for people to volunteer locally. We have initiating something in Mexico, in Haiti, in Rwanda. So there are more options for volunteers to sign up and offer their services. We also are building a network with the free clinics in the US within different cities. So even more local volunteering is available, because even in the US, a lot of cities have a lot of underserved, marginalized populations which don't have insurance, which don't have access to basic health care. So there is scope to volunteer even within the US. And then we have non-medical, and we have medical students and residents who have internship opportunities with us as well. Then we have diagnostics, we have hospitals, we have pharmaceuticals who also can volunteer by providing X number of free tests, by providing the medications, by providing infrastructure in a hospital to do a surgery or to do a procedure. So every stakeholder in the healthcare service delivery, not just a doctor, has an opportunity to volunteer. For example, if we have a cardiac surgeon who says, I will do one free surgery a year, and we have 100 surgeons who sign up, we have 100 free surgeries available. But to do these surgeries, we need an infrastructure. So we reach out to the hospital where the surgeon works to say, give us your operating room for 3 hours or 5 hours for the duration of the surgery for free. And that is their part of volunteering. So we want to engage everyone to volunteer. When it comes to non-medical volunteers, we have a lot of technical needs. We have a website which needs to be updated. We are working on a volunteering app. We're working on information materials, flyers, like we have an animation video on menstrual hygiene which talks about menstrual awareness, sexuality, sexual health for young girls in India. So preparing those kind of things, preparing posters, preparing documentation, all of these need assistance, and then you don't have to be a medical personnel to do any of these. So there are opportunities for everybody in this space, and bringing all of them together and working synergistically is what will give us a holistic solution to help the patient improve their quality of life.
Yes, and it all takes people to come forward and then help in terms of donations. How does this donation stream work? How can people people who are overseas can also donate? How does this whole structure work?
Yes. So people who are overseas can donate to Arogya Seva in the US. So it is also a registered 501c3 nonprofit in the US. So you could issue a check, you could do a direct bank transfer, we could provide you more information if you write to us at donate@arogyaseva.org. So there is, we do have some online campaigns. Sometimes we have a bike tour that's going on, which is a 2,500-mile bicycle tour done by one of our volunteers from California to Florida. So we have an online campaign, but that ends today. So you can still donate through our website in US if you want to, and if you want to donate in India, then we are a Section 25 not-for-profit company in India as well. So you could donate in India also.
Wonderful. Dr. Daya,
and
really...
if you want to donate, just one more point. If you want to donate in kind, we also have an art platform called Art for Arogya, where it's an annual festival. We have something coming up in May, where if you have a piece of art that you would like to donate, or anything in kind, it could be a photograph, it could be a painting, we do have opportunities to donate that, and then we sell that to raise funds as well.
Wonderful. Dr. Daya, I really want to thank you from the bottom of our heart for all the service that you're doing and putting together this platform where people who are doctors and who are non-doctors can still come and then help. And phenomenal work in terms of the Nepal relief, the Chennai relief that we started looking into. And again, keep going. And the humanity, the amount of message that you're spreading in terms of Seva is just incredible. Thank you so much, Dr. Daya.
Thank you. I would like to end by saying Sarve Jana Sukhino Bhavantu, and there is opportunity for everybody to volunteer. It is there within all of us. So I would say just go ahead, commit to volunteer, not necessarily only with Arogya Seva, but with anyone. Volunteer and experience what you get out of it. Thank you so much for having me.
Thank you. Thank you for the message, Dr. Daya. So friends, you heard Dr. Daya mentioning about how each individual can pick up causes and then certainly volunteer and make a difference. So, friends, if you like the show, you should certainly go take a look at their Facebook page, Arogya Seva, AAROGYASEVA. You can just grab for it on the Facebook search line. Also, they're on Twitter as Doctors for Seva. You can see that. And a lot of information on arogyaseva.org. And I hope you've got brilliant insights on what each one can do and how Arogya Seva is basically impacting lives, even when it is a disaster or a lot of people who are left behind in terms of basic health care in a bigger picture of the healthcare industry. Thank you so much, and do come back to NRI Samay. NRI Samay is on Facebook, it's also on Twitter, and you can go visit all the archives on YouTube, youtube.com/NRI Samay, facebook.com/NRI Samay. We are on Twitter handle is NRI Samay. Thank you so much. Have a wonderful weekend.